Welcome everybody for our meeting today organized by Mega Online Anesthesiology course. And we have a great symposium today about the brain death and organ donation. And we have a lot of the speakers, 6 speakers from different countries. So I am sure you will enjoy the meeting. The meeting is organized, as I mentioned, by Mega Online course in collaboration with Abu Dhabi Anesthesia Club. And it is supported by the Egyptian Medical Syndicate and the Egyptian Society of the Anesthesiologists. The good points from Dr. Saad, this meeting is already accredited by the College of the Anesthesiologists in Ireland for 3.5 hours, and this is great job actually from Saad. And I hope all the next meeting will be accredited from the College of the Anesthesiologists in Ireland. By the way, I was qualified from there, so it is my honor to be from this meeting. Moderator with me, Dr. Catherine Mazarway. She is consultant of anesthesia in the ICU, University Hospital in Limerick, and also she is a National Organ Donation Clinical Lead in Ireland. She is the past chair of the National Training Committee of the College of the Anaesthetists in Ireland as well. Also, she is the former president of the Intensive Care Society. So welcome, Dr. Catherine, and she is going to introduce the first speaker, Professor John Doyle. Thank you, student.
Thank you very much. I'm just going to share my screen. I have a little slide here. Our first speaker this evening is Professor John Doyle, and I understand that this is my first time attending this course, and Saad, those of you who are attending may not know, is one of my colleagues in UHL in Limerick. And Professor Doyle, I believe, has contributed on many occasions to the course before. He is the Professor of Anesthesiology in the Cleveland Clinic in Ohio in the United States. And he is going to speak to us today on brain death, non-heart beating, and organ transplantation. He's going to explore the issues, and I think it's a sort of an exploratory talk to start off our evening. Professor Doyle, you are very welcome, and I await your talk with interest.
I'd like to welcome everybody to this talk, Brain Death, Non-Heart Beating Donors and Organ Transplantation, Exploring the Issues. I'm John Doyle, Staff Emeritus from Cleveland Clinic in Cleveland, Ohio, USA. And if you want a copy of this talk, send me an email to djdoyle@hotmail.com, the email address shown here, and I'd be glad to send you a copy. Let's begin by taking a look at the outline of the presentation. I'll begin with some introductory remarks, some historical notes. We'll discuss the various criteria for brain death as it's evolved over time. Then I'll talk about some diagnostic errors in brain death declaration and how there's been some apparent recoveries from brain death reported in the literature. I want to then go on to the question, is brain death testing infallible when executed correctly? And I'll be closing by some commentary on opposition to brain death criteria and non-heart beating donors. You will notice that some topics are discussed only peripherally, and that is because other presentations in this symposium will cover these topics in much more detail. In addition, if you want a lot of detail from a philosophical point of view, my book, What Does It Mean to Be Human? Life, Death, Personhood, and the Transhumanist Movement, published by Springer. Chapter 5 in that book covers a lot of the details that will be covered in this presentation. So some interesting philosophical issues that I'll be covering in this book. A good place to start is with Pope Pius XII. He once said at a symposium, it remains for the doctor, and especially the anesthesiologist, to give a clear and precise definition of death and the moment of death of a patient who passes away in a state of unconsciousness. He made it clear that this is a clinical definition for death, and it is more than simply the departure of the soul from the body. Traditionally, death has been defined as the permanent cessation of the heartbeat and respiration, known as classical or somatic or cardiorespiratory death. But modern developments in resuscitation have forced a reappraisal of this concept. In fact, there are some people who, so worried about being buried alive because of the poor diagnostic skills in ancient times, would have this apparatus such as this shown here, where if it turns out that you weren't dead and you woke up in the coffin, you could signal an alarm using this apparatus here, where you would pull on that lever and a bell would ring and a flag would be raised. So that's how poor people were in the past in diagnosing death. Now let's take a look at brain death itself. It is a modern clinical concept central to the practicalities of organ transplantation, in that most transplanted organs come from patients who have been declared to be brain dead. In a typical clinical scenario, a patient receives a massive injury to his or her brain, for example, from a burst cerebral aneurysm, and ends up in an intensive care unit on a ventilator, as well as possibly receiving other other life-supporting interventions such as drug infusions or blood pressure support or dialysis. While in the intensive care unit, the patient's neurologic status is periodically assessed. And if there is suspicion that the patient is brain dead, a formal brain death evaluation is carried out according to local protocol. If the patient is found to be brain dead, the patient's relatives are then approached regarding possible organ donation. The importance of organ donation for transplantation is highlighted in these figures from the United Kingdom from 2007, showing the number of livers, kidneys, pancreas, hearts, lung transplants that needed to be carried out and that were. For example, in 2007, there were 263 patients awaiting lung transplantation, but only 120 transplants were carried out in 2007. For kidney transplants, the number is much bigger. There was almost 2,000 transplants carried out, and that was based on 1,526 donations. So it's clear that organ donations are driving transplantation. So here we note that the advent of transplantation surgery provided a strong clinical motivation to define death in terms of loss of brain function rather than as a cessation of cardiorespiratory activity. This is because the success of transplantation surgery depends on the use of viable organs uncompromised by circulatory failure. With time, the concept of brain death as synonymous with death of the person has gained almost worldwide recognition. A key physiologic event in brain death is a severe elevation of intracranial pressure, or ICP, from causes such as hemorrhage or edema. When the intracranial pressure rises to approach arterial pressure, cerebral perfusion pressure, CPP, approaches zero. Remember that mean cerebral perfusion pressure equals the mean blood pressure minus the mean intracranial pressure. And as a result, when the cerebral perfusion pressure approaches zero, cerebral perfusion stops and brain death follows. Over time, there's been a variety of criteria for brain death that has evolved. Before the Harvard criteria in 1968, there were criteria that were ad hoc that came out of South Africa at the time of the first human heart transplant. Since then, the Harvard criteria, which depended on the requirement of no response to stimulation in the spinal cord, was replaced by the Minnesota criteria, as well as various other national criteria around the world. And we'll have a chance to talk about some of that as well. The United Kingdom relies on brainstem death-based criteria rather than death of the whole brain. And the President's Bioethics Commission in the USA in 1981 came up with a whole brain criteria definition that is used to this day in the United States and in many other parts of the world. So the legal basis for brain death in the United States is the 1981 report of the President's Commission for the Study of Ethical Problems in Medicare and Biomedical and Behavioral Research. The commission defined brain death as the irreversible cessation of all functions of the entire brain, including the brainstem. Since that time, this seminal report has been used as the basis for much of the discourse on brain death. Here is a brain death checklist based on that criteria. And it starts out with an outline. In checklist A, there should be no spontaneous movements, seizures, or posturing. There should be no response to any kind of to painful stimulation like external rub or pressure on the fingernails in the distribution of the cranial nerves, but spinal reflexes are permitted. There should be absent brainstem reflexes, and we talk about that in checklist B. The patient should be artificially ventilated with an apnea test to indicate no spontaneous respiration. We cover that in checklist C. We want to rule out exacerbating causes, and that's checklist D that I'll be presenting. And then you want to establish the patient's condition is due to irremediable structural brain damage, And sometimes that's clear from the use of angiography, CT scans, or MRI scans. Then you want to verify that the clinical findings are unchanged with reappraisal 2 to 24 hours later. Now, to test for absent brainstem reflexes, the following protocol is recommended. Number 1, fixed dilated pupils with no direct or consensual response to light should be present. Pupils should be mid-size or larger, and care should be taken that atropine or other drugs that block the pupillary response to light have not been given. And we'll have a chance to talk about the importance of the atropine test as an adjunct later on. But this should be done before the atropine test if you're using it. There should be absent corneal reflexes, and there should be absent cold calorics or vestibulo-ocular responses to cold water stimulation. The gag reflex should be absent, and there should be absent responses to a catheter placed down an endotracheal tube into the trachea, and finally, absent Doll's eye phenomenon. In the case of the apnea test, there's multiple steps involved. One should place an arterial line, if not already present, a pulse oximeter, and facilities for arterial blood gas analysis, adjust the ventilator for 100% oxygen, adjust ventilation as necessary to ensure that the arterial carbon dioxide tension is between 30 and 40 millimeters of mercury. Then draw blood gas sample number 1, and using a stopwatch, disconnect the ventilator, insufflate oxygen at 6 liters per minute through a tracheal catheter to prevent hypoxemia, and watch for any movement suggestive of respiratory effort. If there are any movements suggestive of respiratory effort, the apnea test fails. After 10 minutes, disconnect it from the ventilator, draw another blood gas, and reconnect the ventilator. Compute the rise in PCO2 during the apneic period. This rise should exceed 10 millimeters of mercury, and as I've emphasized, no respiratory effort should be present for the apnea test to indicate that no spontaneous respiratory activity is present. The next part is to rule out possible contributing conditions. Number 1, you want to make sure that there are no CNS suppressant drugs like barbiturates and benzodiazepines, or narcotics like opioids that could be explaining what's happening. Second, rule out hypothermia with esophageal or rectal temperature measurements. If the patient's temperature is under 32.2 degrees Celsius, then you cannot diagnose brain death. Finally, you want to ensure that electrolyte disturbances are not present and that neuromuscular blockade has been reversed if it has been given. For this, you'll review the anesthetic record and possibly, if the nerve stimulator so indicates, reverse with neostigmine and glycopyrrolate or other drug. Some points to remember: spinal reflexes may remain intact in brain dead patients. A carefully conducted apnea test with arterial blood gas sampling is necessary for the determination of brain death. And in general, ancillary investigations such as electroencephalography, cerebral angiography, brainstem evoked potentials are unnecessary to diagnose brain death, but they can be useful in difficult circumstances, and in some countries they are required. For example, here is a blood flow study to the head. Notice how, while blood flows to the skull and surrounding tissues are present, there's no blood flow identified within the area of the brain. And this finding is consistent with brain death. Another test that's sometimes used is the atropine test, first proposed in 1975 as an adjunct to brainstem tests. And it relies on the fact that there's only a contribution from the sympathetic nervous system to the heart rate in brain dead patients. This test is considered positive if the administration of 2 to 3 milligrams of atropine fails to increase the heart rate by 3%. Easily done and inexpensive. As I mentioned, you want to rule out some preconditions that might be reversible causes. We have to rule these out or exclude them. Intoxication from drugs like benzodiazepines, depressant drugs like barbiturates, muscle relaxants like rocuronium. Primary hypothermia, you want the temperature to be above 32.2 centigrade. You want to rule out hypovolemic shock, metabolic disturbances, and endocrine disturbances, for example, hypoglycemia. Now, some clinicians have noted that the criteria for brain death are in some respects arbitrary. For example, while the original Harvard criteria for brain death requires the loss of all spinal reflexes, more recent criteria do not. Similarly, the various national guidelines are not all exactly identical, so it's likely that there are some patients who meet some existing national criteria for brain death, yet do not meet others. Here's a review from European literature comparing European brain death codes, a comparison of national guidelines. And what you can see from here is that if you look at the various countries, Austria, Belgium, Denmark, Finland, France, etc., there can be variations. For example, regarding the repetition of testing, some require confirmatory testing, some do not. In the case of the number of physicians, some require 1 or 2, some require 3, some require that one of them be a neurologist or a neurosurgeon, so there's variations. And there's especially variations in confirmatory tests, which in some countries like France, they are mandatory, or in Italy, they are mandatory, but not required, for example, in Poland, and useful as an adjunct in many countries, as indicated for accepted tests on the right. Here for the apnea test, you can see that there's some variations in the arterial PCO2 required prior to testing. And in some countries, it's not even defined, such as in Switzerland. And so you can see that there's a lot of variation in the requirements, so that in fact, you could have somebody meeting the criteria in one country, but not meeting it in the other. So here's the conclusion of that review. The analysis of European national brain death codes demonstrates that the concept of brain death as defining the death of the individual is widely accepted. But the diagnosis of brain death, according to the recommendations of various nations, is a necessary prerequisite for the explantation of cadaveric organs. And yet there is a lot of variation between the nations in terms of what is required. Another concept that comes up is the possibility of diagnostic errors in brain death declaration. These can be of two types. The first type is protocol variations, and this is described in detail in an article by Gail Van Norman from Anaesthesiology from some 20-some years ago. It's called A Matter of Life and Death, What Every Anesthesiologist Should Know About the Medical, Legal, and Ethical Aspects of Declaring Brain Death. And she points out some stories from the literature and elsewhere about patients who were declared brain dead when in fact there was a violation of the protocol. Another situation that's perhaps more interesting is imperfect protocols, where the protocols present may not be detailed enough that there can be some false positives. Two examples are cited here, and I'll give you more in a minute. Fulminant demyelinating neuropathy mimicking brain death, published in 1997 in Muscle and Nerve, and Guillain-Barré syndrome mimicking brainstem death, published in Anesthesia in 1990. Let's take a look at some of these issues in more detail, as well as this case, a case report of increased apnea threshold in a pediatric patient with suspected brain death. So here, a formal brain death examination is performed in a 4-year-old male with the diagnosis of what was an astrocytoma and global cerebral hypoxemic ischemic damage secondary to cardiorespiratory arrest. Patient filled all criteria for brain death except the apnea test. The apnea test was performed for 9 minutes and 23 seconds, at which time spontaneous respiratory effort was noted. The respiratory efforts were initiated with a pH of 7.08 and a PCO2 of 91 millimeters of mercury. In conclusion, then, in this case, the case illustrates that current guidelines for apnea testing may lead to erroneous evaluation of the medullary respiratory drive. Now, it's important to emphasize this being a pediatric case. The whole business of brain death declaration is more complex in pediatrics and requires special experience, and the use of ancillary tests can be especially useful in this setting. Another case report here of Guillain-Barré syndrome, a patient who appeared to meet the clinical criteria for brain death, but in fact was not brain death. And the authors write, this rare case illustrates the risk of injury or death to patients when brain death examinations are performed before the differential diagnosis and prerequisite criteria for brain death are established. Another one that's particularly interesting is successful clinical recovery and reversal of mid-basilar occlusion in clinically brain dead patient with intra-arterial urokinase. And this patient appeared to be brain dead because of a brainstem stroke through a basilar artery occlusion. And when they gave intra-arterial urokinase, they were able to reestablish flow to the brainstem, and the patient recovered from what was apparent brain death. So a question that comes up is the infallibility of brain death testing. And here's a letter to the editor I wrote in Anaesthesiology some 20 years ago. It relates to the review I mentioned by Gail Van Norman carried out earlier. And I write, I must take issue with the implication that well-conducted testing will always correctly indicate whether a patient is alive or dead. As with all complex algorithms, any test sequence for the diagnosis of irreversible brain death may have hidden pitfalls, just as all software of any significant complexity will manifest occasional bugs. If we accept the notion that, as with all medical tests, testing for brain death has an associated sensitivity and specificity, we must also accept the notion that type 1 and type 2 errors mimicking brain death will inevitably occur. This view is also supported by occasional reports of clinical conditions mimicking brain death. Finally, if one accepts that the notion that still living but impaired brainstem nuclei may sometimes recover to a degree, it is possible that some nuclei will wax and wane in function during the test period. And this may come up in particular in the case of apnea testing that I'll be commenting on a little bit later. Another issue that comes up is the issue of irreversible loss of function of the entire brain. So the President's Commission in the United States defined brain death in terms of irreversible cessation of all functions of the entire brain. In the years since this definition was offered, it's become eminently clear that many and perhaps most patients diagnosed with brain death do not actually meet this criteria because they still have some pituitary function, because they're not in diabetes insipidus. And so that means that the definitions are not always being used as one might expect. An interesting issue is what should be done if the formal brain death criteria are met only imperfectly, such as where all the criteria for brain death are met, save one. An example of this scenario is the patient who meets all the criteria for brain death, except he or she still has an intact gag reflex. So the traditional teaching here is that you would wait until the brain death criteria are met, or in some cases, one might go for another definition of death based on a period of asystole after the withdrawal of care. A comment on this will come up later. Now, there has been some opposition to brain death criteria. Here is Michael Potts from the Philosophy and Religion Department at Methodist College, and he points out that there are a number of experts who feel that brain death criteria are not as they should be. The concept of brain death should be abandoned. And those of you who want more details, there's a series of articles that are presented here. Some defenders of brain death fail to acknowledge that such a debate exists. When they do notice that their position is attacked, they behave like individuals whose religious orthodoxy has been questioned and merely repeat the position that brain death is death without presenting arguments for that position or seriously addressing the arguments of their opponents. So because there can be opposition to brain death, particularly on religious grounds, the question comes up, what should doctors do when a patient in an ICU is declared brain dead, but according to their family's religious beliefs is still alive and must continue to be given treatment? So two camps here. On the top, we have the Jewish position, and they talk about two UK pediatric ICU doctors describe how they resolve such a difficulty by allowing their patient, an Orthodox Jew, to remain on mechanical ventilation until she died from natural causes. And more about this in a moment when we talk about a formal position from the Jewish authorities. But two Australian intensive care specialists that are commented in this article believe that unreasonable delay in stopping treatment serves neither the interests of the patient nor those of society and can be difficult for staff, as well as involves the expenditure of enormous degree of resources. In the case of the US perspective, here is a review by Rappaport and Rappaport about principles and concepts of brain death and organ donation, the formal Jewish perspective. In 1987, the chief rabbinate of Israel accepted the performance of heart transplantation in Israel based on the declaration of brain death of the donor. They had some criteria. They recommended knowledge of the cause of the illness, complete cessation of spontaneous ventilation, presumably via an apnea test, clinical demonstration of the destruction of the brainstem, and there's investigations for that, particularly examining the brainstem nuclei clinically. Objective support for clinical determination of brainstem auditory evoked potentials. This is a useful way of establishing the brainstem is dead, but not required in many nations. A demonstration of absent respiratory and brainstem activity for at least 12 hours under full therapy. So the Jewish position is that brainstem death is not recognized by Orthodox Jews as death of the individual. Families should not be pressured into consenting to the withdrawal of care. Rabbinical authorities should be consulted for moral guidance if Orthodox Jews declared brain dead while being mechanically ventilated. Compromises that are acceptable to medical and nursing staff are usually possible. And asystole usually occurs within a few days of brain death, even if limited supportive care is continued. However, it's worthwhile pointing out that some people have been maintained with a good cardiac function for days and even weeks after the declaration of brain death. And so that can be an issue in terms of the resources used. Similarly to the Jewish position, the Islamic position will vary depending on what nation you're in. And some countries like the United Arab Emirates now accept brain death. Nevertheless, there are some individuals of the Islamic persuasion who are reluctant to accept brain death. Now, a contrary view is that a delay in stopping treatment can become unreasonable and unfair. And the authors here say that delay in stopping apparently futile treatment of a brain dead patient is often required where the arrival of a close relative is awaited or the family needs time to adjust or accept an inevitable, though often sudden death. In an affluent society, this seems to be a reasonable compromise. Even if one does not accept the concept of brain death, it is hard to argue that the patient has any interest in continued treatment after brain function has stopped irreversibly. Staff caring for the patient may have difficulty reconciling the apparent misuse of scarce resources or the compromise of a patient's dignity, that is, ventilating a corpse. Non-acceptance of brainstem death precludes beating heart cadaveric organ donation. While this non-acceptance systematic to an ethnic group, organ transplantation will become more difficult because of histocompatibility genes clustering in these groups. More poignantly, the authors write, should transplantation be facilitated in groups who, because of their beliefs, cannot participate in organ donation? Furthermore, is it reasonable to offer a more expensive treatment option such as dialysis when a cheaper option like renal transplantation is rejected on non-medical grounds? So this is an example of the debate from the literature. Another issue is the question of whether apnea testing is harmful because of the rise in PCO2 that occurs. This author here, Coimbra, writes that when you have damaged brains with Glasgow Coma Scale in the range of 3 and cephalic areflexia, with patients who are still in the global ischemic penumbra region with a brain flow between 10 and 35 mils per 100 grams of brain tissue per minute. You can get exacerbation of the injury with brain death testing through the apnea test because it may induce arterial hypotension and indeed even cardiac arrest, as well as an increase in ICP due to hypercarbia. So this was his position that he published in the Brazilian Journal of Medical and Biological Research. This has been critiqued by Hayfield, a consultant neurologist at Queen Elizabeth Hospital in the United Kingdom. His article, he writes, suggests that cooling patients who are demonstrating absent brainstem function due to structural brain damage will improve their chances of regaining brainstem function, and he simply says it's not true. He writes that hemodynamic disturbances which occur when brainstem death has occurred and is being tested are more often than not independent of the testing process itself. Cardiac arrest and arrhythmias are a common occurrence when rapid increases in intracranial pressure occur with hypothalamic injury. The practice of inadequate resuscitation of patients with diabetes insipidus and poor venous filling pressures because of their underlying pathologies, in my view, a much more likely cause. A particularly controversial approach to brain death is that from the philosopher Peter Singer, who is professor at Princeton University. Singer takes the position that brain dead individuals are in fact still alive, but the organ procurement or organ harvesting from these individuals is nonetheless acceptable. His position is rather employ an artificial, contrived, or bogus definition of death. We should recognize that the only intellectually honest course is to admit that all lives are not equally valuable, and that some lives are indeed in such a degraded and hopeless state that even though they are technically alive, it is still ethically acceptable to utilize their organs for transplantation with approval of the appropriate family members. Now, let's close with the discussion of non-heart-beating organ donors. In more recent times, the lack of a sufficient number of organs from brain-dead donors has led to the occasional use of non-heart-beating organ donors. Here, the patients who are not brain-dead, but have no reasonable chance of recovery are brought to the operating room where they are prepped for surgery, followed by the withdrawal of all life support measures. Sometime later, their heart stops. A period of time after that, typically 300 seconds or 5 minutes after the final heartbeat, surgeons quickly rush in to retrieve organs before they deteriorate. Some individuals have criticized the definition of death used in non-heart-beating organ donation programs, noting that any cessation of cardiac activity or asystole might not necessarily be permanent as long as the heart might be restored by vigorous resuscitation efforts. In addition, several non-heart-beating organ donation protocols allow anti-mortem drug administration and other interventions that are not intended to benefit the donor. For example, high-dose heparin is sometimes given to prevent blood clotting. However, since the heparin is not administered for the benefit of the patient, some professionals argue that its administration may be unethical. Here's a comment from the Canadian Journal of Anesthesia. With the need to reduce warm ischemia, organs must be recovered as quickly as possible after the cessation of cardiac activity. The simple question becomes, when in the course of ascertaining death is the patient dead, and when can organs be taken? They go on to write, the recent Institutes of Medicine report identified variability between centers in the duration of asystole required prior to organ retrieval, 2 to 20 minutes, and that limited research has been conducted on the likelihood of spontaneous autoresuscitation. Their report recommended adoption of 5 minutes of observed cardiac asystole, with the caveat that further research is required to confirm that autoresuscitation does not occur during this period. Meanwhile, some centers continue to use an interval of asystole as short as 2 minutes. Despite the premise of a certainty in determining irreversible death, it is worrisome that some centers cannot agree to adopt a common standard. That brings us to the end of the discussion. And I remind everybody that if you need a copy of the slides, you can contact me at djdoyle@hotmail.com, djdoyle@hotmail.com. Again, thank you very much for the time that you spent. And thank you again for